Hi, good morning. Today I'm going to just talk about Henoch Purpura. It is also called as IgA nephropathy. Okay. I will start with a case presentation which we had in our hospital around a few months back, or you can say that. This is a Lebanese child, 6 years and 9-month-old child, presented with history of fever for almost 2 to 3 days with erythematous rash. It was erythematous purpuric rash over both leg and extended up to back and buttocks. There was history of vomiting continuously 3 to 5 times before the admission, and there was poor oral intake. And they have noticed that there was a pain over the both ankle as per the mother. There was abdominal pain on the day of admission when we admitted the child. There was abdominal pain. This child was seen in clinic few days, 1 day back, and it was started only on antipyretics and symptomatic treatment. You can see that there is a rash. You can see on the ankle and on the leg this erythematous purpuric rash. Okay, it was extending up to buttocks and on the ankle. So initial investigation was done, basic investigation was done, CBC, CRP. CBC was normal. Mostly white blood cells were normal, but differential neutrophilic predominance. CRP was high, 35. Electrolyte panel, there was mild dehydration. Rest electrolytes were normal. Urea creatinine was normal. LFT and ESR was 9. LFT was normal. Urine analysis was showing ketone positive 50, but WBC only 2 to 4. No red blood cells in the urine. Stool analysis was showing occult blood positive. Stool PCR was negative. Ultrasound abdomen was done to be sure that there is no, because there was abdominal pain, to make sure there is no intersubmission or acute abdomen. It was noticed that there was a around loop, there was some fluid, mostly on Rasheed fossa, and few small mesenteric lymph nodes. During the admission, the pain was aggravated and baby was vomiting. So CT abdomen was done to confirm if there is any, to rule out any acute abdomen like intersubscription and all. It was showing the same findings as in ultrasound. That's there was a small fluid in right iliac fossa with mesenteric adenitis. ANCA was sent, it was negative, and skin biopsy was done during the admission. Skin biopsy was showing features of leukocytocyclistic vasculitis and IgA positive vascular signals. It goes consistent with HSP. We had started symptomatically initially the treatment with IV fluids, some antipyretics, NSAIDs, and additional rosufen was added because of mesenteric adenitis and high CRP. On day 3, we started on methylprednisolone, and Flagyl was added after CT toxin was positive. The course of during the hospital stay, the child was continuously to have vomiting in first 2 days of admission with abdominal pain and poor oral intake. Abdominal pain was just paraumbilical, and on day 3, we noticed that there was a blood in the stool, and there was a loose watery stool, but there was blood in the stool. Because of rash and symptoms, we had initially suspected of vasculitis or HSP, so which was confirmed by biopsy as the child symptoms were aggravated with vomiting and diarrhea with blood in stool. So GI involvement was there. So methylprednisolone was added on day 3, and child was being regularly followed by our team of doctors, gastroenterologists, and surgeon to rule out if there is any intersubmission and all. Okay. On day 6, we noticed that there was ecchymosis and purpuric rash was increased during hospital stay. So on day 6, the steroids, the child started responding to steroid on day 6. Till then, the baby was continuously having abdominal pain, blood in stool. My oral intake was slightly improved during the hospital stay. There was no fever during hospital stay. After starting steroid, there was no fever. And the blood in stool started getting better after a couple of days of IV steroids. So child was being discharged on day 11 with no abdominal pain and no blood in stool, and there was no joint pain also. So after I just took a pictures just to be sure the rash, progress of the rash on after the 3 weeks of discharge. You saw almost getting, the rash is getting started fading up, the purpuric rash start getting disappear. So I'll just give a brief introduction about HSP, okay, or Henoch purpura. It's an acute immunoglobulin IgM mediated disorder, okay, and HSP is the most common systemic vasculitis of child presenting with triad of purpuric rash, arthralgia, abdominal pain, and renal disease. Almost 95 to 97 to 100% of the cases will present with purpuric rash. Okay. It is the most common childhood vasculitis. It is small vessel disease with IgA deposition. Annual incidence is 10 to 30 cases per 1,000 children less than 17 years of age. Mean age of presentation is 6 years, with most cases below 10 years. It is more common in boys than girls. HSP is predominantly a cold month of the year. It has been reported worldwide. It can be presented after upper respiratory infection. It's followed sometime with upper respiratory infection. Regarding the syndrome, the name, it was first seen by a German physician. His name was John Schönlein, which described pilosis rheumatica or arthritis with rash. After 30 years after this one, they noticed there was GI manifestation. So Henoch was, so the name was being described as Henoch Schönlein purpura. What are the commonest causes associated with HSP is Streptococcus species or Yersinia or parvovirus, adenovirus, mycoplasma, EB virus, or varicella. Drugs associated with HSP is penicillin, ampicillin, erythromycin, quinine, quinidine. Some vaccines also associated with HSP disorder like typhoid or paratyphoid, measles, yellow fever, and cholera. It has been reported that. It's a prodrome associated with headache, child will present with headache, vomiting, or anorexia, fever. Okay, and after prodrome, their appearance of rash will be there. Abdominal pain can appear with peripheral edema, especially legs and scrotum and all. And some babies will have either vomiting or arthritis can develop if the other symptoms has been involved. Skin involvement. This is the diagnostic in any HSP cases. The rashes appears in almost 100% of the patients, and it includes the lower trunk, lower extremity, and buttocks and perineum. The rash typically appears in a groups with new groups appearing in waves. Rash begin as a maculopapular rash. Initially, it will be blanch on pressure and progress to purpura. Palpable purpura involved from red to purple to rusty brown and fades away. Almost more than 50% of the patient can also have GI involvement. For that, we have to keep continuous monitoring if the patient develops anybody who has abdominal pain, nausea, vomiting, because it is associated with intersublution and acute abdomen. So it's been closely monitored. The most common symptom is colicky abdomen and peritoneal exudates, mesenteric lymphadenitis, or hemorrhage in bowel. Intersublution is one of the complications of HSP. Bone involvement, almost 75% of the patient, 25 to 75% of the patient can have bone involvement. Initially, 25% will have large joint pain, knees, ankle are most commonly involved, and edema also can be a symptoms, one of the symptoms. Arthritis is resolved completely without, over several days without any permanent articular damage. Almost 30 to 50% of the patient will have renal involvement. It persists as long as 6 months after onset of the rash. And mild to moderate cases, up to 1 to 3% of the cases can land up into end-stage renal disease in this. Manifest in the range of mild hematuria or proteinuria to oliguria and renal failure. These are the criteria which has been suggested by pediatric rheumatology and international trials. It shows that purpura is mandatory in diagnosis, and at least one of the following should be there, like abdominal pain, histopathological features of vasculitis, and arthralgia or renal involvement, especially proteinuria more than 0.3 gram over 24 hours. What are the basic investigations in this? Actually, this symptoms is mostly resolved by itself, okay, almost most of them. But if the patient is having any other complications, so we can investigate the child to rule out if there is any blood loss or anything. The CBC has been done. It will show anemia or leukocytosis. Thrombocytosis can also happen. Some babies, they can show ESR rise. There will be immunoglobulin, IgA, IgM can rise. Urine can show WBC or RBCs or cast, and albumin can also present in mild to moderate case. Brain enema, it is diagnostic or therapeutic to rule out if there is any intersubstitution. Skin biopsy is one of the gold standard for diagnosing HSP. Renal biopsy in if there is no resolution, so of proteinuria or hematuria, so it can be done renal biopsy to see if there is any renal end-stage renal disease or not. It should be done after 6 months of steroids, 3 to 6 months of steroids. There will be deposition of IgA, IgM or C3 and fibrin deposition. Regarding the management of HSP, it is basically supportive therapy. It is mostly supportive therapy. Symptomatic treatment can be required by NSAIDs and all. And in mild to moderate or complicated case, immunosuppressive therapy can also required. Supportive care, basically, it should be a monitoring of any complications, good hydrations, NSAIDs to relieve the pain, okay, and like monitoring for the development of any complications. Symptomatic, mostly NSAIDs are used to relieve the pain for arthralgia, abdominal pain, or any kind of pain. Okay. Use of glucocorticoid. It is recommended if it can reduce the it can shorten the duration of abdominal pain and decrease the risk of intersubstitution or decrease the risk of surgical intervention. But it cannot prevent any end-stage renal disease. As per couple of trials has been shown that it doesn't prevent end-stage renal disease, but it can shorten the duration of hospital stay or abdominal pain relief and all. It cannot be recommended for each and every patient who comes with HSP unless and until you see any mild to moderate involvement of other system like renal or gastrointestinal or joint involvement. So mostly corticosteroid we are using only during the hospital stay of the hospital, hospital stay only. It can require intravenous pulse methylprednisolone therapy for 3 to 6 months of age if there is any rapidly progressive glomerulonephritis or nephrotic syndrome. Methylprednisolone is used only in severe form of HSP. Indication of glucocorticoid usage are persistent nephrotic syndrome, or if there is a crescent more than 50%, or severe abdominal pain, as I told, or substantial GI hemorrhage, or severe soft tissue edema, severe scrotal edema, or any neurological involvement, or intrapulmonary hemorrhage. Other immunosuppressive therapy of HSP nephritis is used in patients with severe kidney involvement, like proteinuria or progressive renal failure, as it has been documented. Some of the trials or some of the literature shows that 1 to 5, some of the maximum shows 1 to 5% of the child can develop into end-stage renal disease, but in adult it is the percentage is up to 11%. There are a variety of agents being used as mostly immunosuppressive drugs are often used in combination with IV or oral steroid have been studied for prevention and treatment of kidney disease. Most evidence consists of case reports or small cases series with few randomized trial and results have been mixed. There's no conclusive result which immunosuppressants should be used. These are the agents which they are using, azithromycin or cyclophosphamide or cyclosporin. These are the agents they are using in combination with IV steroids or oral steroids. Mostly cyclophosphamide has been recommended. I guess my nephrology colleagues can comment on that. This is one of the flow chart been suggested by Royal College, how to, if a case you suspect of HSP, how to follow and what kind of things should be done. Like you can follow the patient with renal, child with fever or abdominal pain or rash. We can see urine analysis if it is normal and all. If it looks well, there is no involvement, then we can discharge and follow in clinic. If there is any addition, like if there is any involvement of testicular or poor oral intake or pain is severe, peritoneal pain, then we can involve other team, start steroids and all, and can follow the patient to prevent any other complications, especially renal involvement. after discharge, like in first 1 week, and then up to mostly up to 1 year, you have to follow regularly the child. Complication involved with HSP are nephrotic syndrome, as I told, end-stage renal disease or interstitial. During interstitial, they can have bowel perforation. There can be having male child testicular torsion. If not controlled or not investigated well, can land up into chronic hypertension, seizure, paresthesis, and coma. Rare complication can have cardiac involvement or mononeuropathies or pancreatitis or pulmonary or intramuscular hemorrhage. Prognosis of HSP. In most of the cases, the children outcome of HSP is excellent with spontaneous resolution of symptoms and signs. HSP can reoccur in 1/3 of the patient, typically within 4 months of initial presentation. Recurrent purpura can be occasional, associated with joint complaint and episodes of gross hematuria, although each subsequent episode is generally milder and shorter. This long-term morbidity of HSP is related to degree of HSP nephritis. Some of them will eventually progress to end-stage renal disease is required for kidney transplant. Aim of initial follow-up is to identify patient with worsening kidney involvement, especially serial urinalysis, blood pressure measurement, blood test to assess kidney function, and exclusion of other cause of glomerulonephritis. In our case, we had to follow the child for 6 months, and there was no any renal involvement. Child was perfectly all right. Last few months back, I saw the child is growing well and all. Patient with compromised renal function should, while taking NSAID, should be very careful to monitor, especially Brufen and Voltaren or diclofenac. Should be closely monitored because of renal involvement. Should see if there is any dehydration or blood pressure monitoring, or renal function should be monitored. Mild renal involvement like microscopic hematuria or mild proteinuria does not require biopsy or immunosuppressive treatment, but this children will require close follow-up. Patient with severe abdominal pain needs prompt evaluation and investigation to exclude any interstitial. In case of sudden change of mental status, to rule out any intracranial hemorrhage should be excluded as appropriate for the imaging. Thank you.